Hi everybody, welcome to part one of two presentations on the thoracolumbar spine. So we will start with a look at the routine projections for the thoracic spine and for the lumbar spine, and then we'll go on to look at the columns of Denis and the factors that affect spinal stability. Then we're going to look at spinal injuries, both traumatic and pathological, wedge compression fractures, burst fractures, chance fractures, fractures, dislocations, and then finally we'll have a look at the importance of the paraspinal line.
The standard projections for the thoracic spine are AP and lateral. On your AP view, you want to be able to see C7 all the way down to L1. Now, although your vertebral bodies get slightly bigger in height as they progress further more distally, the difference between the contiguous vertebra shouldn't be that significant. So if you get marked narrowing of a vertebra, that'll indicate you've got an underlying abnormality. Look at every single pedicle. Can you see them all? Look at your spinal processes. They should run down the midline. Although having said that, the majority of adults have a very slight mid-thoracic scoliosis, convex to the side of their dominant hand due to their muscles being more stronger on that side. But like the cervical spine, the key thing about the spinal processes is looking for the interspinous distance, and is that equidistant as you work your way down. If you have diastasis, that will indicate that you've got an abnormality to the posterior elements. Look at your paraspinal line. Can you see it clearly? If you've got any bulging or swelling to the paraspinal line, that will indicate that you've got an underlying abnormality, such as a fracture or pathology. Have a look at your ribs. Check the soft tissues of both not only the lungs but also the visualised abdomen. Now, with the cervical spine, most of our injuries are either flexion or extension. But once you move to the thoracolumbar region, then they're primarily flexion injuries. And if you do have another type of mechanism, then it tends to be in addition to a flexion type injury. If you think about it, your upper and mid-thoracic vertebra are protected by your rib and your sternum, and this renders that area relatively immobile. So when most people sustain injuries, it tends to be T11 down to L2, and that's where we start moving away from the rigid spine to a more flexible region. And so that's why we tend to get these injuries at that location. Unfortunately for motorcyclists, they tend to injure between T2 to T8. They tend to be pretty awful injuries. So with our lateral, we want to be able to see the whole of L1, and we want to go as far proximal up the thoracic spine as possible. Now, we find it quite difficult to visualise T1, T2 usually because of the overlapping shoulders and scapula. And so therefore, if you do have an injury to the upper thoracic region, you're going to have to do a swimmer's view. So like your cervical spine, we want to be interested in our lines. Make sure that your anterior longitudinal line is in alignment. Look at your posterior longitudinal line, that should be in alignment too. This is a beautiful picture. Quite clearly see the intervertebral foramina. You want to go around the cortex of every single vertebral body so you don't miss an underspace fracture. Look at intervertebral disc spaces, are they all of a similar size? There's no diastasis or marked compression. This is, again, as I can say, this is nice. We can actually see some of the spinous processes. You don't always get the ability to see the spinous processes on a thoracic spine. Now, I appreciate it's quite difficult to appreciate on this view, but what you're looking for is a gentle posterior concavity to the posterior borders. We'll look at that in more detail. And then also, don't forget to check the soft tissues and any of the ribs. So for our lumbar spine, we have a AP and lateral as well. Now we should be able to see the whole of T12, all the way down to see the inferior portions of the sacroiliac joints. So you definitely want to get those on. Look at your vertebral bodies, go around the cortex of all of them, making sure that they're nice and square. Look at your pedicles. Look at your spinal processes, checking your interspinous distance. Importantly, look at your transverse processes. You can get isolated fractures of the transverse process, and you won't appreciate these injuries unless you look for them. Look at your ribs. On your lumbar spine, look for your psoas shadows if you can see them. Obliteration to the psoas shadow may indicate a massive hemorrhage within the abdominal cavity. Look at your SIJs, make sure you don't have any diastasis or any disruption. Look at your arcuate signs, make sure you don't have any fracture running through them, indicating a fracture through the sacral foramina. Check your iliac crests, have a look at soft tissues. Some people present with back pain when actually they've got renal colic. Okay, so again, for a lateral, you want to make sure you've got on T12, you want to clearly visualise L5, and you want to be able to visualise the L5S1 intervertebral disc space and part of the sacrum. So you want to go down your anterior longitudinal line, and that should be in alignment. Then go down your posterior or up your posterior, and again, the alignment should be preserved. Check around the cortex of all your vertebral bodies. Now you can get slight wedging around the thoracolumbar region, which is normal, okay? So just sort of, so in this particular patient, we can see the slight wedging of L1, but actually this is not abnormal, this is a very normal picture. So get used to looking at the thoracolumbar junction and what the normal appearance of the vertebral bodies in that location is. Check your intervertebral disc space, make sure that there's or in alignment, that there's no diastasis or narrowing. L5S1 intervertebral disc space tends to be slightly narrower than the remaining vertebral body disc spaces, as are the thoracolumbar intervertebral disc space and the thoracic vertebral disc spaces. Look around your pedicles, and then specifically look for your pars ventricularis. Assess your facets, check your ribs, go around your spinous processes. Now we frequently get lumbarization or sacralization. So lumbarization is when S1 turns into the appearance of a lumbar vertebra, and sacralization is when L5 turns into a sacral vertebra. So what I want you to get into the habit of doing is identifying L1 and then count down 1, 2, 3, 4, 5. Okay, that's good. So now you can go up 5, 4, 3, 2, 1. Now look for your rib. You need to do this every single time. Lumbarization and sacralization of the lumbar spine is very, very common. So you frequently get 6 lumbar vertebrae if there's been lumbarization, or 4 lumbar vertebrae if there's been sacralization. So when we talk about, check to see that you've got a slight posterior concavity to the vertebral bodies. That's normal, that's important. Check you don't have any wedging, any undisplaced fractures. Don't forget to look at the soft tissues as well. Okay, so we briefly talked about the 3 columns of Denis on a cervical presentation, but we'll just quickly recap it. So the principle behind the 3 columns of Denis is that if you injure one column, then your injury is considered to be stable. However, if you injure 2 columns or more, then this is considered to be an unstable injury. So very quickly, as I said, the anterior longitudinal line is the anterior longitudinal ligament, which runs down the anterior vertebral body. The posterior longitudinal ligament is tightly bound to the posterior vertebral body. Then you've got your ligamentum flavum, and then you've got your supraspinatus ligament. So your anterior column consists of your anterior longitudinal ligament, 2/3 of the anterior vertebral body and 2/3 of the annulus fibrosus. Your posterior column involves the posterior third of the vertebral body, the posterior third of the annulus fibrosus, and your posterior longitudinal ligament. So what happens with your posterior column is that basically it's everything posterior to the posterior longitudinal ligament, which means your pedicles, your facet joints and articular processes, your ligamentum flavum, your neural arch and interconnecting ligaments. So instability is when you have disruption of two continuous columns. For example, your anterior column and your middle column, or your posterior column and your middle column, or all three. So as we've discussed, your classic wedge fracture that you see in the thoracic spine in older people, this is considered to be a one column injury, so it's stable. But a burst fracture, that involves two columns, so this is unstable. And when we also think about the criteria for stability, if the angulation of the fracture is greater than 20 degrees, or if there's a translation of more than 3.5 millimeters, then that's also considered to be unstable. So our classic mechanism of injury for the thoracolumbar spine includes hyperflexion, which results in a wedge fracture. Hyperextension injury, these tend to involve a tear of the anterior longitudinal ligament, so therefore you're looking for intervertebral disc space diastasis. This isn't particularly common. Now axial compression injuries, that's our burst fractures. You've got distraction injuries, which tend to be just purely ligamentous injury, and these are really rare, so I wouldn't worry too much about that. Shearing results in ligamentous disruption, and then rotation results in facet joint and combination injuries, or you tend to get complex or combined vectors. So hyperflexion is the primary injury, and then everything else is in varying degrees that's usually associated with a degree of hyperflexion. Unsurprisingly, the major reason for spinal trauma is RTC, also falls from a height, sporting injury, and then of course penetrating trauma. Now in the thoracolumbar region you tend to get an awful lot of pathological fractures, usually from osteoporosis, that would be the real main thing. And then also tumours, so METS tends to favour the axial skeleton, particularly in the vertebral column. And then of course you've got pre-existing disease such as Paget's, so you can get pathological fracture through those. Okay, so the really high energy vertebral fractures we think of are wedge. Now most of these are stable, but occasionally some are unstable. And to assess for instability is that you're really looking at your pedicles. If you've got widening of the interpedicular distance, that will indicate that the wedge fracture has moved through into the pedicles involving the posterior elements. Burst fracture is unstable, and then a chance type fracture is also unstable. Fracture dislocations are highly unstable. They're quite often associated with the motorcyclists. Now, if you get a transverse process fracture, if it's just isolated, then it's considered to be a stable injury, but often it is associated with other injuries. So what are the important things to check for? So on your lateral view, you're looking for loss of intervertebral height or wedging. You're looking for that loss of the normal concavity of the posterior border of the vertebral body. Do you have any detached fracture fragments from the anterior vertebral body? And remember, if you see one abnormality, keep searching. Are there multiple abnormalities? If we look at this image on our right, we can see there's a wedge compression fracture. Okay, 5, 4, 3, 2, 1, and then we can see our rib. So we know that this is L1. So first of all, you check your anterior vertebral line. So even though you have a bit of diastasis of intervertebral disc space, or you have narrowing of the thoracolumbar intervertebral disc space, this alignment, the anterior alignment, is still preserved. Remember, I was talking about the posterior curvature of the vertebral bodies. We can see them quite clearly here. And if you look at L1, you can still see that there is still a little bit of posterior curvature. And so this means that the posterior elements have not been disrupted. So this is an anterior column injury, and the middle column has not been affected. So when we look at a compression fracture, what we're looking for is assessing the loss of anterior vertebral body height. Now, people often grade compression fractures, grade 1, grade 2, grade 3, grade 4. So grade 1 is up to 25% of loss of the anterior vertebral body height. Type 2 is up to 50% loss of the anterior vertebral body height. Type 3 up to 75% loss of the anterior vertebral body height, and then type 4 up to 100%. Now, I think percentages are quite hard to work out, so I think the best way to assess for compression fractures is it mild, moderate, severe. So mild, we're looking about 1/3, moderate is 2/3, and then severe is complete, more than 2/3. So in this particular instance, we're looking at probably a moderate. If you compare T12, the height of T12 and the height of L2, we can see that there's probably about 50% loss of vertebral body height, so I'd call that a moderate wedge compression fracture. So what is it? It's a compression fracture where L1, how? Wedge compression of the superior end plate with loss of anterior vertebral body height. Now don't forget, we have to look at all the other vertebrae. Go around the cortex of all of them. Have a quick look at your pedicles, look at your facets. These facets are lovely. Check your pars articularis. Have a quick look at your spine, have a look at spinal processes. So we've got no disruption to the posterior elements at all. So this is essentially a stable fracture. A burst fracture is a very specific type of compression fracture. Now the key mechanism is it's an axial force. So this axial force compresses the nucleus pulposus, which then explodes out into the vertebral body, which causes a centrifugal displacement of the fracture fragments. So on our AP view, let's go around the cortices of all our vertebral bodies. And we can see that L1 vertebral body is compressed in comparison to the appearances of T12 and L2. So we have a reduction of the intervertebral height. So therefore this is an anterior column injury. Now let's look at our pedicles. And here we have diastasis of the pedicles. And the best way to check that is by looking at T12 and L2. So we have widening of the interpedicular distance. So if we have widening of the interpedicular distance, this means that it's got to have an injury involving the pedicles. Now if the injury involves the pedicles, that's a posterior column injury. So suddenly you have two column injury. This is an unstable injury. Look at your interspinous, look at your spinous processes. Actually, they're not too bad. Quickly have a look at your ribs. Look at your transverse processes. Okay. Now with a burst fracture, what you're looking for is a vertical fracture to the vertebral body. I appreciate on these images it's not great. If you look along here, this is the superior vertebral end plate of T12, this is the superior vertebral end plate of L2, and we can see this sclerotic line indicating the depression of the superior vertebral end plate of L1. And if you take it from me, this lucent line is our horizontal fracture. Let's look at our lateral. So we'll look at our anterior line. Anterior line doesn't appear too bad. Let's look at our posterior line. Now, do you remember L2 is a really good example here. Can you see this very shallow posterior curvature of the body of the posterior cortex of L2? That's the normal appearance. Now look at L1. We can see that there's been retropulsion of the posterior vertebral cortex towards the spinal canal. So we have disruption of the anterior column, we have disruption of the middle column, and then the interpedicular widening indicates there's disruption of the posterior column. So this is a 3-column injury. So we've got disruption to the posterior longitudinal line. You need to look carefully because sometimes you will see a small fracture fragment within the spinal canal. And as you can appreciate, it's really hard to appreciate the significant posterior elements, including the spinous processes. But we know that this is an unstable injury, and so this is a very classic appearance of what's known as a burst fracture. So what is it? Burst fracture, where L1 have burst fracture with loss of anterior vertebral body height and diastasis of the interpedicular distance. Now for the Brucey bonus points, you have to say that you've got loss of the anterior vertebral body height and you need to say you've got diastasis of the interpedicular distance, because therefore you are telling your person that this is a two-column injury, or in fact in this particular instance it's a 3-column injury, indicating that this is an unstable injury to get your full marks. Okay, so our checklist on our AP view is our thoracic spine. You're looking for displacement widening of the paraspinal line. Trauma, you're looking for a fracture. If you've got widening of the paraspinal line and not in the context of trauma, then you need to be thinking about underlying pathology. In the thoracolumbar region, you need to be looking at increasing the interpedicular distance. You want to check your spinous process for alignment and if they're equal distance apart. And remember to check your fractures on the spinous processes. So just to demonstrate in close up, this is our paraspinal line, and it should run fairly close to the left border of the vertebral bodies. You can see a right paraspinal line in some people, very infrequently, so don't get too bogged down with that, because an absent right paraspinal line does not mean anything significant. So this is our paraspinal line, and don't get confused with our descending aorta. This is a good example of an abnormal paraspinal line. So this is a patient that was in resus, and the radiographer did a chest x-ray. Now remember when I said the paraspinal line, it should lie fairly tightly against the left lateral border of the vertebral body. So here are vertebral bodies and here is our paraspinal line. It's really quite large. This black line, that's our descending aorta. This is an excellent reason why you should always do dedicated thoracic spine views. I know people occasionally cheat and they will actually crop a chest x-ray and think that that's an adequate thoracic spine view, and it's not. You need to have an adequate penetration. So here's a well penetrated AP thoracic spine, and suddenly we can see that we have a wedge fracture of T, what's that one? It's 10, 11, 12, so T9. The interpedicular distance looks well preserved, so this is not involving the posterior column. The interspinous distance is normal, so there's loss of vertebral body height, so there's probably a compression fracture. So this line here is our abnormal paraspinal line. it's raised in comparison to what it normally it looks like. Remember, it should be tucked in nice and close to the vertebral bodies, and here it's raised, and here is our descending aorta. So the paraspinal line can be extremely helpful in identifying abnormalities. So do try and make a look out for it. Transverse process fractures can be in isolation, or they can be part of a number of associated injuries. They're frequently overlooked, particularly if they're isolated. We seem to forget to look at them for some reason. I'm not sure why. Maybe it's because they're often obscured by valgus. Your psoas muscles inserts to your transverse process, so you can get multiple fractures of the transverse process on one side where the psoas has literally just pulled them off. They can be quite widely displaced. Let's quickly assess this image. Okay, let's go around the vertebral bodies. One, two, three, four, five. That's sacred. Okay, so the vertebral body heights have been well preserved, so we have no concerns of a compression fracture. Let's have a look at our pedicles. We can see all our pedicles, and there's no diastasis of the interpedicular distance. So we're happy there's not a posterior column injury. Let's have a quick look at our spinous processes. And they're all in alignment. There's no diastasis of the interspinous distance. So we're definitely very happy that there isn't a posterior component involved. Quickly check your ribs. All right, let's have a look at the left transverse processes. Just like a quick look at our iliac crest. On the other side. Okay, so L1 transverse process looks good. L2, very difficult to appreciate, but there is actually a fracture of the tip of the transverse process of L2. We can quite clearly see the fracture of through the mid portion of L3 with some diastasis. L4 transverse process is this just tiny lucid line, so it's only really L3 that's been slightly distracted. So what is it? It's a fracture where L2, L3, L4 right transverse processes, how minimal distraction. A chance fracture is frequently mistaken for a burst fracture. It's not. It's a completely different mechanism caused by hyperflexion. The nickname for a chance fracture is a seatbelt fracture, and that's because it tends to occur in patients who are wearing a lap belt without a chest restraint. Let's think back, let's look at our spine. The spine has the fulcrum at the posterior third of the spinal column, and this allows us to flex forward and to extend back. If you're unsure of what I mean by fulcrum, think of a seesaw with a person sitting at each end. The fulcrum is in the centre of the seesaw, so as one person goes down towards the ground, the other person lifts up. When the other person moves down, the other person lifts up. So it allows the vertebral body, so the vertebral column, to flex forward and extend back, flex forward, extend back. Now the problem is that when you're wearing a lap belt without a chest restraint, is that when the car deaccelerates very quickly, the lap belt brings the fulcrum to the anterior abdominal wall. And because it brings it to the anterior abdominal wall, when you hyperflex forward, it changes the fulcrum, which creates the tension to rip through the posterior elements, and it results in a horizontal fracture through the vertebral body. So remember, a burst fracture, what happens is that you get a vertical fracture through the vertebral body, you tend to get marked compression of the vertebral body height, and you get widening of the interpedicular distance. Now here, because you have this horizontal injury, we can see that it's ripped through the spinous processes. So let's look at it on the AP view. So we start off going around our vertebral bodies, and we can see that there is slight loss of vertebral body height in relation to L2 and L4, but not much, only a little. Now let's look at our pedicles. We can immediately see that we've got widening of the interpedicular distance, so we know that the posterior elements must be involved. Now let's look at our spinous processes, and this is the key. So we have a spinous process here and we have a spinous process here, but there is no spinous process overlapping the vertebral body. This is called the empty vertebra sign. And so therefore, to get an empty vertebra sign, it must mean that the spinous process has been distracted so that it no longer appears on the AP view within the vertebral body. So we have this horizontal fracture through the spinous processes, it goes through the pedicles, it then comes out, there's a little line through here, and then it comes out through the superior vertebral end plate. So this is a really unstable injury. Let's have a look at our anterior vertebral line. So there is some loss of the anterior vertebral body height of the superior vertebral cortex, but actually the alignment seems relatively well preserved. Let's have a look at the posterior vertebral line, and we can see, so remember you're looking for that nice posterior curvature of the vertebral bodies, and we can see we've got retropulsion through the pedicles, which cause the diastasis of the interpedicular distance. So remember, let's go over this one more time. A burst fracture is a vertical fracture through the vertebral body. You get marked compression of the vertebral body height. You get widening of the interpedicular distance. Now the chance fracture, you get a horizontal fracture through your vertebral body. You may get some compression of the superior vertebral end plate, you may not, but you get ripping out through the pedicles and the spinous processes, so you get your empty vertebra sign and you get widening of the interpedicular distance. So what is it? It's a chance fracture. Where? L3. How? Horizontal fracture through the spinous process, pedicles and the vertebral body with only slight loss of anterior vertebral body height. Fracture dislocation is a really significant injury. If you can remember, the spinal cord terminates at the L1, L2 interface. On this particular patient, the injury is at L2, L3. And so if the quadra equina is completely transected, what's going to happen is that you're going to get disruption to the brain-leg interface. And that will include your thighs, your groin, your hips, and it may even affect your anterior abdominal wall. So let's have a quick look at this patient. If we come down the vertebral bodies, we can see that the proximal vertebrae are completely in alignment. Spinous processes run down the midline. When we get to L2, we can now see that there's lateral translation. There's a large fracture fragment, and we can't see our pedicle on the left, indicating there's been disruption to the posterior column. If you look at the distal portion, there's been rotation of the vertebral bodies, which we can tell by the orientation of the spinous processes in relation to the proximal portion. Just quickly go around the rest of that. Now let's look at our lateral view. So let's come down our anterior longitudinal line, and we can see at L2, L3, there's now posterior displacement of L2 in relation to L3, consistent with the retrolithesis. If you come down the remaining of the anterior vertebral body, the alignment is preserved. Let's have a look at our posterior vertebral bodies. Now remember, on the AP view, the proximal portion is AP, but on the distal portion is in rotation. So conversely, on our lateral view, we can actually see the complete vertebral bodies, the squaring of the vertebral bodies of the distal portion. So at this point, L3, 4 and 5 are oriented in the pure lateral position. Whereas if you come up the posterior column, we can see the posterior cortex of the vertebra, indicating there's a degree of rotation. So it makes it quite difficult to assess the posterior vertebral line. But certainly the posterior vertebral line along here is normal. If you look carefully, you can actually see a fracture fragment within the vertebral foramen. So what is it? It's a fracture dislocation. Where? L2-3. How? Retrolithesis of L2 onto L3 with lateral translation. We've come to the end of part 1 and I look forward to chatting to you for part 2.